Welcome to vpod.ai.
Great to be here.
This deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor for pretty much everything: enterprise data storage, backup, DR, hyperconverged, cloud.
Both public and private cloud solutions. Definitely check them out at stonefly.com for more info.
Okay, so let's dive into something really fundamental: swallowing.
Something we usually don't even think about.
Exactly. We're taking a deep dive today into a condition called achalasia.
Right, Achalasia.
Our mission really is to unpack this. It's often misunderstood, maybe misdiagnosed sometimes.
That can happen, yeah.
So we want to explore what's actually going on inside the body, how experts figure it out, and, what they can do about it.
Based on what we know today.
Right. So by the end of this, you should have a clearer picture of the symptoms, maybe why it happens, the diagnostic process.
Including some specific tests.
Yes, and the different treatment options out there.
Sounds good.
So let's just jump right in. When we talk about achalasia, what exactly is it? What are we dealing with?
Great place to start. So fundamentally, achalasia is a swallowing condition. It impacts the esophagus.
The tube from the mouth to the stomach.
Exactly that tube. The core issue is nerve damage within the wall of the esophagus.
Nerve damage.
Yeah. And because of that damage, the muscles in the esophagus just can't contract properly. They can't do that coordinated wave, to push food and liquid down towards the stomach.
So the normal peristalsis, that movement, it's just not working right.
It's impaired, definitely. And there's another part to it. The muscle at the very bottom, that ring called the lower esophageal sphincter.
The gateway to the stomach.
Right. It's supposed to relax and open up when you swallow to let things pass through. In achalasia, it doesn't relax properly. It stays too tight.
So it's a double whammy. The tube can't push effectively, and the door at the bottom won't open fully.
You got it. That's the essence of the problem.
So the consequence must be things get backed up.
Precisely. Food, liquids, saliva, it all collects in the esophagus because it can't get into the stomach easily.
What happens then? Does it just sit there?
It can sit there, yeah. And sometimes it can ferment, which isn't pleasant. It can also wash back up, regurgitate into the mouth. And people often describe a bitter taste when that happens.
I can imagine. So the main symptom people notice must be difficulty swallowing, that feeling of things getting stuck.
Absolutely. That's the #1 symptom. The medical term is dysphagia. It's that sensation like food or drink just isn't going down right, like it's lodged somewhere.
Usually in the chest, maybe.
Often felt in the chest, yes.
Now, people might hear food coming back up and think reflux, like GERD. Is there a difference?
Oh, that's a really critical distinction. Thanks for bringing that up. They can feel similar sometimes, but the source is different.
How so?
With achalasia, the material coming back up is from the esophagus itself. It never reached the stomach. With GERD, it's stomach contents, acid, and food coming back up from the stomach.
Okay, so it's about where it's coming from. That's key.
Exactly. It tells you if the problem is the esophagus not emptying or the stomach valve letting things back up.
Got it. What other symptoms might someone with achalasia experience besides the main difficulty swallowing?
Well, besides the food coming back up, you might also notice saliva coming back up. Heartburn is common, belching too.
Heartburn?
Yeah.
Even though it's not stomach acid?
Yeah. The retained food can irritate the esophagus, causing a burning sensation that feels like heartburn. Also, chest pain can occur. It might come and go.
Okay.
Coughing, especially at night, can be a symptom. And because it's hard to get food down properly, significant weight loss can happen over time. Vomiting, too.
The weight loss makes sense if you just can't eat effectively.
Right. And there's one more serious potential complication we need to mention.
Oh.
Pneumonia. If food or liquid accidentally goes down the wrong way into the lungs, that's called aspiration, and it can lead to pneumonia.
Wow, okay. That's serious. And you mentioned these symptoms often start gradually.
That's right. It's usually not something that hits hard overnight. It tends to creep up slowly and worsen over months or even years.
Which might make it harder to recognize initially.
It can, yeah. People might adapt their eating habits without realizing why for a while.
Okay, so we understand what it is and how it feels. But why? Why do those nerves get damaged? This is where you said it gets interesting.
It really is, because honestly, the exact cause is still, poorly understood. We know there's a loss of nerve cells in the esophagus, but why those cells are lost isn't entirely clear.
So, no single smoking gun?
Not yet. There are leading theories, though. One idea is that a viral infection might trigger it somehow. Maybe the virus directly damages the nerves, Or maybe it sets off an immune reaction.
An immune reaction, like the body attacking itself.
Exactly. An autoimmune response is another strong possibility. The immune system mistakenly targets those esophageal nerve cells. And then, in very rare cases, it might be linked to an inherited genetic disorder or even a specific type of infection, like Chagas disease, though that's much less common in many parts of the world.
Fascinating. It sounds like there's still a lot to learn about the root cause. Are there certain people who are more likely to develop achalasia? Any risk factors?
There are a couple of things we see. Age seems to play a role. It's most often diagnosed in adults between, say, 25 and 60, but it really can affect people of any age, even children.
Yeah, okay.
And certain underlying medical conditions seem to increase the risk a bit. Things like allergic disorders, adrenal insufficiency, or a very rare genetic condition called Allgrove syndrome.
Allgrove syndrome. Got it. So, if the symptoms can overlap with other things and the cause isn't always clear, diagnosing it sounds like it could be tricky. How do doctors actually figure out for sure that it's achalasia?
You're absolutely right. It can be overlooked or misdiagnosed initially. That's why specific tests are so important. A healthcare professional won't usually diagnose it just based on symptoms. They'll recommend testing.
What kind of tests are we talking about?
The gold standard, really the most helpful test, is called esophageal manometry.
Manometry. What does that involve?
It involves passing a thin tube through the nose down into the esophagus. This tube has sensors that measure the muscle contractions as you swallow sips of water.
Ah, so it measures the pushing action.
Exactly. It measures the strength, the coordination, or lack thereof of those contractions. And crucially, it measures how well that lower esophageal sphincter, the LES, relaxes and opens during the swallow.
So it checks both problems.
Yeah.
The pushing and the opening.
Precisely. It gives a really detailed picture of the esophageal function and is key for distinguishing achalasia from other swallowing disorders.
Okay, that sounds very specific. What about see what's going on? Imaging.
Yes, imaging plays a role too. Often an X-ray study called a barium swallow is done.
Barium. That's the chalk you drink.
That's the one. You drink this liquid containing barium, which coats the lining of your digestive tract. As you swallow, X-ray images are taken.
What does that show?
It lets the doctor see the silhouette of your esophagus, stomach, and upper intestine. In achalasia, they might see a dilated or widened esophagus because food isn't emptying well. They might also see a characteristic narrowing at the bottom, sometimes called a bird's beak appearance, where the tight sphincter is.
Bird's beak.
Interesting. Sometimes they'll also have you swallow a barium pill or tablet to see if it gets held up and passes through very slowly.
Makes sense. Any other ways to look inside?
Yes. Upper endoscopy is another common procedure.
Like a camera scope.
Exactly. A thin, flexible tube with a light and camera on the end is passed through your mouth down the esophagus and into the stomach.
What's the goal there?
It allows the doctor to directly look at the lining of the esophagus and stomach. They can check for inflammation, rule out other causes of symptoms like tumors, though those are rare causes of achalasia-like symptoms. They can also take small tissue samples, biopsies, if needed, maybe to check for complications.
Biopsies. Okay.
Sure.
And I think I read about some newer technology too.
You might be thinking of FLIP technology, functional luminal imaging probe.
Right. FLIP.
It's a newer technique. It uses a balloon catheter with sensors to measure the distensibility or stretchiness of the esophagus and the opening of the sphincter. It can provide additional data to help confirm an achalasia diagnosis, especially if the manometry results are maybe a bit ambiguous.
So it sounds like it often takes a combination of these tests to really piece it together.
Often, yes. Manometry is usually key, but the others help build the complete picture and rule out other possibilities.
Okay. So once someone gets that confirmed diagnosis, what happens next? What are the treatment options?
Right. So the goal of treatment isn't really a cure, unfortunately, because the nerve damage itself is considered permanent.
Ah, okay. So it's about managing the symptoms.
Exactly. The focus is on trying to get that lower esophageal sphincter to relax or stretch open more easily, so food and liquid can actually pass into the stomach without getting stuck.
Targeting that tight muscle at the bottom.
That's the main target. And the specific treatment choice really depends on the person, their age, their overall health, how severe the achalasia is.
Makes sense.
Yeah.
What are the options that don't involve, major surgery?
Okay, so non-surgical approaches. One common one is pneumatic dilation.
Pneumatic.
Yeah.
Like air pressure.
Yes. It's an outpatient procedure, usually done with sedation. An endoscope guides a balloon down to the tight sphincter. The balloon is then inflated forcefully to stretch and widen that muscle opening.
Does it work? Is it permanent?
It can be quite effective, but it often needs to be repeated. Studies suggest maybe around a third of people need another dilation within 5 years or so.
Right, so potentially repeat procedures.
Potentially, yes. Another non-surgical option is using Botox injections on a botulinum toxin A.
Botox, like for wrinkles.
Same stuff, different application. It's a muscle relaxant. It's injected directly into the sphincter muscle using a needle passed through an endoscope.
How long does that last?
That's the catch. It's temporary. The effects usually wear off within 6 months, sometimes less, sometimes a bit more. So injections need to be repeated regularly to maintain the benefit.
And any downsides besides being temporary?
Well, repeat injections can sometimes cause scarring that might make later surgery more difficult if it becomes necessary. Because of that, Botox is generally recommended more for people who aren't good candidates for dilation or surgery, perhaps due to age or other health issues.
Interesting.
But an interesting side note, if someone has a really good, strong improvement after a Botox injection, it can actually help confirm the diagnosis of achalasia.
Ah, like a therapeutic trial.
Sort of, yeah. Finally, there are some medicines, muscle relaxants like nitroglycerin or nifedipine. You take them before eating.
Do they work well?
Honestly, their effect is pretty limited for achalasia, and they can have significant side effects like headaches or low blood pressure. They're really only considered if the other options, dilation, surgery, Botox, aren't suitable or haven't worked. It's rarely the main therapy.
Okay, so those are the non-surgical routes, often temporary or with limitations. What about surgery?
Surgery offers a more potentially permanent solution by directly altering that sphincter muscle. The most established surgical procedure is called a Heller myotomy.
Myotomy, cutting muscle.
Exactly. Myo for muscle, myotomy for cutting. The surgeon cuts the muscle fibers of the lower esophageal sphincter. This relieves the pressure and allows food to pass into the stomach much more easily.
How is that done? Big incision.
It used to be, but now it's almost always done using minimally invasive techniques, specifically laparoscopy. Small incisions, camera, specialized tools, quicker recovery.
Okay, that sounds effective. But if you cut the muscle that stops reflux, does it cause reflux?
That's a great question, and yes, it can. Loosening that valve can increase the risk of developing GERD or acid reflux later on.
So you trade one problem for another.
Potentially.
Oh.
But surgeons are aware of this, so very often they perform another procedure at the same time as the Heller myotomy to prevent future GERD. It's called a fundoplication.
Fundoplication. What's that about?
The surgeon takes the upper part of the stomach, the fundus, and wraps it partially or fully around the lower end of the esophagus. This essentially creates a new artificial anti-reflux valve.
Ah, clever. Building a new valve.
Kind of, yeah. And this, too, is usually done laparoscopically along with the myotomy.
Okay, so Heller myotomy, often with fundoplication. Any other surgical approaches?
There's a newer technique that's gained popularity called POEM. P-O-E-M.
Poem. Like poetry.
Stands for peroral endoscopic myotomy. Peroral means through the mouth.
Ah, so no external cuts at all.
Correct. It uses an endoscope inserted through the mouth. The surgeon makes a small incision in the inner lining of the esophagus, tunnels down to the sphincter muscle, and then cuts the muscle fibers from the inside. Similar muscle cutting as a Heller myotomy, just accessed differently.
Wow, that sounds quite advanced. Does POEM also have the GERD risk?
Yes, it can also lead to GERD, possibly even more frequently than Heller myotomy with fundoplication, because the anti-reflux mechanism isn't typically reconstructed during POEM itself.
So how is that managed if it happens after POEM?
Often, if GERD develops after POEM, patients are treated effectively with daily acid-suppressing medications. Sometimes, a separate, later fundoplication procedure might be considered if GERD is severe, or in some centers, they might explore combining POEM with some form of endoscopic fundoplication.
So several options, each with pros and cons to weigh.
Definitely. The choice involves a detailed discussion between the patient and their doctor about their specific situation and preferences.
It really makes you think. So bringing this all together, what does learning about achalasia mean for you, listening to this?
Well, I think it highlights just how incredibly complex and finely tuned our bodies are. Something as seemingly simple as swallowing involves this intricate coordination of nerves and muscles.
Something we totally take for granted until it goes wrong.
Exactly. And when it's disrupted, like in achalasia, the impact on daily life can be significant.
And understanding the symptoms, knowing that there are specific tests to diagnose conditions like this, and seeing the range of treatments. It's not just interesting medical info, is it?
Not at all. It really underscores the importance of, well, paying attention to your body's signals. Persistent difficulty swallowing isn't something to just ignore.
Right. seek proper medical evaluation.
Definitely. And it also shows that even for chronic conditions where there might not be a cure in the sense of reversing the underlying damage, effective symptom management can make a huge difference to quality of life.
That's a hopeful note.
I think so. Managing the condition effectively is the goal.
So maybe a final thought to leave people with.
Maybe just this. Consider how a symptom like difficulty swallowing, which might seem straightforward, can actually be a signpost pointing towards a really nuanced underlying problem. It reminds us that getting to the bottom of health issues often means navigating layers of complexity, needing specialized tools, and importantly, tailored treatment strategies. It's not always a simple fix.
A great reminder that our bodies are complex systems. This has been a really insightful deep dive into achalasia. Thank you for joining us.
My pleasure. And we also want to thank our sponsor, Stonefly, again for supporting this deep dive.
Absolutely. And Stonefly has a specific offering worth highlighting. A 100 TB immutable and air-gapped SSO NAS, network attached storage, for $8,995.
That's a serious amount of secure storage. Immutable, air-gapped. Really important features for data protection today.
For sure. You can find out more about that and all their enterprise solutions at stonefly.com.
We hope this discussion gave you some valuable insights into achalasia or maybe just sparked some curiosity.
Thanks for tuning in. Until next time on vpod.ai.